Next it's me. So I'm a consultant dermatologist here at Guy's and St Thomas's Hospital. I've been the lead for the severe HS service for the last coming up to 5 years, and I've got a special interest in trials and the development of new treatments to try and help manage people's HS and keep things under control for them. I did a PhD, which was in stem cell therapy, but for a rare genetic blistering disorder. But it really was when I did this PhD and used a novel treatment for patients that I realized the only way to advance therapies and to advance people's management forward is by being able to do clinical trials, because the better the treatments are, better the education is, the better hopefully outcomes for patients that live with HS. So I'm just going to share my screen. Is that coming up okay?
Yeah, we can see it, Ellie, that's good.
Okay, great, thank you. I'll just see if it's advancing forward, 1 second. Yeah, perfect. So Mia talked a lot about treatments that patients can sort of embark on themselves, or some self-help measures. My talk is largely about prescribed treatments, prescribed medical treatments for the HS population. So every patient that we see within our service, and we've got, you can be seen in a normal dermatology clinic, a general dermatology clinic, and then the severe HS service is really reserved for those that have severe HS and usually have been managed at other hospitals local to them. And they've reached the end of their treatment ladder and they want some assistance with further therapies. But bearing this in mind, any patient that enters our service, we always go back to basics. And one of the most straightforward treatments to try and help aid people's HS and bring things under control are topical treatments. I'll also talk about antibiotics and then other therapies that are on the horizon. So everyone that's in the service usually is advised to use some sort of antimicrobial wash. There are 3 main antimicrobial washes. One is Hibby Scrub that most people are familiar with. Hibby Scrub, however, is a little drying, and because of its drying nature, often people don't use it every day for their when they're washing. That's not because HS has anything to do with hygiene or poor hygiene. Just by using an antimicrobial wash, we can keep the ecosystem that lives on our skin in balance, and it tends to improve patients' outcomes. And even in clinical trials, an antimicrobial wash is recommended for each patient that enters a clinical trial. So there's Hibby Scrub, and then Octenisan is sort of a middle road. So this is a wash that foams up nicely and can help keep the ecosystem that lives on our skin, so the microbiome, stable. And if people are still getting dry with Octenisan, then we use a treatment called Dermol 500 lotion. And those are available to buy over the counter. Then when a patient has HS, we want something to treat the large area that's usually affected. And we usually use something like a topical antibiotic. And the most commonly prescribed one that we use here in the UK is clindamycin. The brand name is usually Dalicin T, and there's also Zindaclin that can be used. Lots of patients come having used topical fusidic acid. The only problem with fusidic acid is you can develop resistance to it quite quickly. So we don't tend to use it as a long-term antibiotic topical treatment strategy. Now, for the patients that get inflammatory bumps on their skin that are red and painful, sometimes having something in your toolkit to apply directly onto that inflamed bump can be helpful. And the most common topical steroid that we use, so this is given for a short period of time, usually for a maximum of 4 weeks, is something called Fusibet, which is a combination of fusidin and betnovate, or something called betnovate C, which is a combination of betnovate and an anti-yeast, anti-inflammatory agent called cleoquinol. There are a few supply issues with betnovate C at the moment, so most patients are having Fusibet prescribed. And then lastly, if patients are developing lots of those blackhead type lesions or comedones, as we refer to them, then using a topical vitamin A related product can be helpful. And the commonest one that we use is something called Epiduo. Topical vitamin A products or topical retinoids can be a bit irritant. And so it's just most of the time I ask patients to just get used to applying it to a small area, and if they can tolerate it okay, then they can build up the surface area that they're using it on more gradually. Patients with HS usually report some benefit with bleach baths and Epsom salt baths. And bleach baths don't work by killing the bacteria. What it does is it reduces inflammation in the skin, some of the skin-related itch that patients suffer with, and some of the pain that they have. And by using an antiseptic antimicrobial wash, we reduce the risk of antibiotic resistance when we do prescribe antibiotics for patients. And I'll talk about antibiotics in a lot more detail. Sometimes patients tell us that it's really difficult to apply topical treatments because when you're rubbing it in, it hurts and the site is already painful. So what I usually suggest in that circumstance is either to gently wipe the area dry and then put a little bit of the treatment product onto a bit of gauze or onto the underside of a dressing, and then put that dressing or bit of gauze onto the skin and then cover it up. And then that way you're not having to rub it in, but you're getting the effect of the topical treatment onto the area that you want it in. So antibiotics, lots of patients that come to clinic will say, oh, we've been given loads of antibiotics and none of them ever do anything, and they're tired of being pushed forward with antibiotics. And so it's just important that we understand why and how we're using antibiotics, and just to address some of the concerns that patients usually report. So the goal of antibiotic treatment isn't to treat an infection, although we do use antibiotics to treat infections as well in the context of HS. But most of the antibiotic treatments that we usually give over these long periods of time are to try and reduce inflammation. And if we can reduce inflammation in the skin, we can hopefully reduce the redness, the pain, the number of boils, and the frequency of flares. The antibiotic choices are usually ones that can be given over a long period of time. So one similarly to when we use in acne. So we use these over many months for a maximum of up to 2 years to try and keep inflammation under control. And just to reassure everyone, we have a microbiologist in our clinic just to make sure that we're using antibiotics appropriately. And if you were to get an infection, that you would still be able to respond to antibiotics. So we use them in a safe manner so that we can treat the inflammation whilst not compromising your ability to respond to an antibiotic should you have an infection in the future. So the commonest treatments that we usually give, so topical clindamycin, so that's the one I mentioned on one of the early slides. We usually give oral tetracyclines. So this is first line treatment. Limacycline or doxycycline is usually prescribed for a minimum period of about 12 weeks. And the reason for that is it takes about 8 weeks to start seeing some benefit. So to withdraw it after a week or two, you sort of haven't had enough time to benefit from the treatment. And then it's been withdrawn. So we usually give it for a minimum of 12 weeks. And at that 12-week mark, if it's making a difference, then we would continue it for up to a maximum of 2 years. But we usually do an assessment every 3 to 6 months to ensure people are still deriving a benefit from it. I usually tell patients that giving treatments in HS doesn't mean that your HS will be completely switched off. I wish there was a treatment that could do that very effectively, but the aim is to try and improve the symptoms, reduce the frequency of flares, reduce pain, reduce discharge, and reduce the level of inflammation. Should single agent antibiotic treatment not be helpful, sometimes we combine antibiotic treatments, and the commonest combination antibiotic approach is this combination of rifampicin and clindamycin, which many of you may have already had or been treated with. Again, this is given for a period of at least 10 to 12 weeks. And in our service, if patients have responded well to that combination treatment, then it can be continued for usually a maximum of approximately 1 year. There are some patients where it's been continued for longer than that period of time, but usually you'd have an assessment to just determine how long to continue it for. We would never use rifampicin on its own because there's a high risk of developing resistance to it, but clindamycin can be used on its own. The combination of rifampicin and clindamycin needs monitoring of blood tests. There are a few alternative treatments should someone be trying to conceive or be pregnant. So we can use the topical antibiotic lotions without any problem, short courses of antibiotics, so antibiotics such as coamoxiclav, which is a combined antibiotic in one, and then longer term options can include cefalexin and erythromycin. Cefalexin is also a well-tolerated antibiotic. People usually talk about sort of strong antibiotics or not so strong antibiotics, but really it's about whichever antibiotic controls that patient's HS and gives them the least amount of side effects. And everyone's response to antibiotics and side effect response will be different. We have a microbiologist in our clinic, and that's so helpful so that we can make sure that we're using antibiotics appropriately in the service. We always take into account what medication patients are on and what their comorbidities are, and whether we should consider an alternative that doesn't interact with drugs that they're already taking for any other reason. So the main side effects when people take antibiotics. So it can reduce the healthy bugs that live within our bowel, and it can also reduce the healthy bugs that live within our vaginal, with part of our vaginal flora. So one of the side effects is that patients can develop thrush. In some patients that can develop thrush, we sometimes give the anti-thrush medication, so a single dose of a tablet called fluconazole alongside the prescription, so if they were to develop any symptoms, they can then take the tablet to treat that. Feeling sick and having diarrhea, with some antibiotics, that's a short-term side effect, and once your bowel adjusts to it, then things are usually better tolerated. So it's normally the first week or so. HS can be associated with other bowel conditions like inflammatory bowel disease, Crohn's disease, and something called ulcerative colitis, and this can make taking antibiotics a little bit more tricky. How long do you need to take them for? So I've already touched on this, but HS symptoms improve usually whilst on antibiotic treatment and can worsen once the treatment stops. What I normally do in clinic is we give antibiotic treatment. If things are working well, then great, we would continue it. And if things start to stop working, then we may adjust it to another type of treatment or another type of antibiotic. But if things are working very well and we've reached the sort of 1 year mark, then we may give a trial of stopping it and having an antibiotic holiday, a bit of time without the antibiotic, see how the symptoms fare up. And if things were to recur, then they could always be restarted. Long-term treatment with antibiotics is sometimes used to help manage HS over a longer period. And if antibiotics are helpful with no side effects, then we do continue them over a couple of years. There are 3 tablet treatments that we would usually move on to if antibiotics haven't been effective. And the 3 main category of drugs that we use in HS clinic, if we were to move away from antibiotics, dapsone, acitretin, and isotretinoin. So I'll talk about them in a little bit more detail. So if we've not had a response to combination or single agent antibiotics, then dapsone can be used. So dapsone is historically a type of antibiotic, but we don't use it for its antibiotic purposes anymore. It works by lowering a type of white cell called the neutrophil count and reducing the inflammatory response caused by neutrophils. It has to be very closely monitored in terms of blood test monitoring. And so it's not a tablet that we could just prescribe and sort of not see someone again. You'd have to be counseled about all the risks and side effects, and blood screening would have to be performed. Acitretin is a high-dose vitamin A type treatment, and this drug can be very effective, particularly for patients that have the blackheads that are developed, and it can dry up some of the discharge that patients develop. We wouldn't use this in women that are of childbearing age, predominantly because you can't get pregnant for 3 years after stopping treatment. And so that's quite a long period of time for women of childbearing age. So we don't usually offer it as an option unless there's a particular reason that we would consider it. A closely linked drug to acitretin is isotretinoin, sort of like cousin drugs. They both are vitamin A type drugs, so retinoids. Isotretinoin works very well for acne, and it's got a lot of an evidence base for working well in acne. The evidence base for it working in HS is much less, so we would give it to patients if they had acne as well as HS to improve their acne, so that might improve them overall, and it might have a secondary benefit for their HS as well. There are a few alternative drugs that have a limited evidence base, but we do use them in our clinic. One such drug is spironolactone. So spironolactone works particularly in women where they have a hormonal flare, in women that have a female pattern of hair loss, or acne affecting the lower third of the face. It's a drug that is used off license for hormonal patterns of acne, and it's used in the HS service, but it has a very limited evidence base for its use, but we do use it. The dose is between 50 and 150 milligrams, and blood test monitoring has to be done if you're to use this drug. Metformin, patients might be familiar with. This is a drug that's usually used in the context of diabetes and also in the context of polycystic ovaries. And it's the reason why it can be helpful in HS is because it lowers levels of circulating hormones called androgens. And so in patients that have hormonally driven HS, which for many patients that is the case, using a drug like metformin can improve that. Metformin also has a secondary benefit of sometimes helping with weight loss, and it's completely safe to use in pregnancy. The biggest side effect with metformin is that it can cause patients to feel sick and cause gastric side effects, so diarrhea. And so in that context, we usually give a modified release version of metformin, which is sometimes better tolerated. There's only one biologic that's licensed and approved for use in HS, and that's a drug called adalimumab. So adalimumab, that has various brand names. So there's Humira, Amjevita, Idacio. These are all brands of this one drug, adalimumab. And the reason why we use this is because a clinical trial was done and it showed benefit in patients that were treated on adalimumab versus those that were treated with placebo, so not the real drug. And since that data was published and that clinical trial information was published, that drug is now available on the NHS for patients that have HS. Part of the criteria that has to be met in order to have adalimumab is that the patient has to have trialed a combination of antibiotics or have a contraindication for a combination of antibiotics. And if we look, don't worry about looking at this slide, but essentially when we looked at the adalimumab treatment arm versus placebo, so those not receiving the drug, in one arm of the study, 41.8% of patients received at least a 50% reduction in their inflammatory nodules and no increase in the number of their draining tunnels. And in a parallel study that was done at the same time, the results were better. So in 58.9% of patients, they achieved that 50% response, so a 50% reduction in their inflammatory nodules with no increase in the number of abscesses or draining tunnels. That's compared to 27.6% of those that were receiving the placebo. So patients may ask, how long do I have to be on this drug to see some sort of benefit? So the effect of a biologic may not be seen right away. Different people respond differently to the same treatments, and we usually give it at least 3 months for a chance to work. I'm very briefly going to touch on a few of the other drug classes which are coming through for management of HS. So a clinical trial has been conducted called the SUNNY studies by a company called Novartis, which is looking at blocking a pathway of our immune system called IL-17 with a drug called secukinumab. And that trial data has been presented at a conference and published and should be hopefully available. It's going through the approval process with the National Institute of Clinical Excellence. A similar drug that works by blocking other receptors on the IL-17 pathway is bimekizumab, and again, that's in the process of being approved. So this is great news that hopefully we'll have 2 further treatments that work on the same pathway but slightly different receptors will be made available for treating HS. In clinical trials at the moment is a drug that works by blocking another inflammatory pathway. So they look at HS skin and HS patients' blood and look at these various inflammatory markers. And these markers are raised in patients with HS. And so the theory is that by lowering them, we should have an improvement in patients' HS. So spursolimab is a drug that blocks IL-36, which is found in high levels of patients with HS. And so that's coming through to clinical trial. IL-1 is a cytokine that causes inflammation, and that's high in patients with HS. And there's 2 drugs that are due to be put through, that are going through the trial paperwork at the moment. So anakinra and lutikizumab. And just finally, there's another class of drugs, so JAK inhibitors. So these are proteins that get messages to the inside of cells. And there's 2 JAK inhibitors that are currently in the process of starting clinical trials with. And some may be familiar with some of these drugs because they are being used in other skin conditions, such as eczema. So what does the future hold? So studies show that almost half of all HS patients are dissatisfied with the current treatment options for their HS. So it's really important that we do find new treatments for them. Clinical trials are underway to find these new treatment options for patients. And it's exciting. This is the first time really that we're developing such an interest and so much awareness of HS. And the more awareness, the more pharma will start promoting and investing in clinical trials to hopefully be able to identify treatment options that are helpful, and there is hope for the future of HS treatment.